First, I'd like to thank the association, Dr. Rose and Dr. Coble for putting this together, and apologize for you for my very poor speaking skills and my jet lag. I just came back from Tokyo yesterday. The opportunity that we have here is a great one because there can be absolutely no culpability when you're beyond the horizon. So we can really just kind of spitball the ideas around. And that, on the other hand, there are some trends in industry today that really give us an idea of what it is that our industry is going to look like in the next 20 to 30 years. It was said that the only constant is change. And when Dr. Coble asked me to describe what the optometric practice might look like in 20 or 30 years, I thought it might be appropriate to go back 20 or 30 years and understand the degree of change that we've experienced since then. The nexus point of science, technology, what's happening with patient demographics and the medical economy are really driving us to some decision points here that are probably mandatory as opposed to optional. The presentation that I'm putting forth to you today is called The Borderless Office. Academia, industry, and practitioners like yourselves have been responsible for keeping us on the cutting edge. And I think what you're going to see is that that level of change will probably accelerate, not stay the same in the next 20 years or so. So if you hadn't recognized yourself, let's see, we can't see it up there, can we? There we go, there's the presentation. You're on the left. This guy, a good-looking guy sitting in this cockpit, is the representation of the optometric office of the future. Looks more like a high-tech cockpit in an aircraft than it does like a traditional office for an optometrist. And I think maybe after the next few minutes, you may start to agree with me that this is the future of your office. On the right-hand side, you see your patient. She's sitting at home. She's being scanned on that device that you see coming off of her computer, and the doctor is collecting the information. This is an amazing statistic. This is an iPhone 5S. The Cray supercomputer back in the late 1980s, early 1990s that broke the human genome had 270% less computing power than does this little device right here. That suggests very big change based on the ability to collect, analyze, store, and retrieve data and transfer those data that are truly becoming huge in their bits and bytes. We talked about that human genome. Today, you can have yours in just a few days. Swab the inside of your cheek, send the kit in, and it's back to you within a week. Huge changes. This slide suggests just how long I've been in the industry. When I joined, the only way that a doctor could diagnose or check the progression, regression of retinal disease was through instruments like the retinoscope, fundus camera, and slit lamp. Even more important, those tools were absolutely worthless in the hands of anybody except a trained optometrist or a trained ophthalmologist. You couldn't possibly perform eye care diagnosis outside of the office. Look where we are today. This automated instrument that you see on the right-hand side, not only is it multifunctional, but it includes databases, it includes very easy to read suggestions on whether a patient is well within normal limits, that patient is borderline, or that patient is suffering from disease, and it can be operated by really just about anybody. This is a harbinger of change all by itself. The fact that it is so easy today to, thank you, Mitch. It's so easy today for us to get the information that we need to help with patients' diagnoses. In 20 years, the need to place instruments like this in the office won't exist. We'll be able to have them virtually anywhere where we decide it's important to collect patient data. Big data and the cloud are part of our lexicon for the last 18 months or 2 years. But what does it really mean to us? Today, when you are in your office and you're getting information off of your OCT or your visual field analyzer, the normative databases that you're using to try to determine whether or not that patient is within normal limits are measured in the hundreds of patients. Imagine the ability to go on the cloud and compare that patient's results to thousands, tens of thousands, hundreds of thousands of patients in a library that helps you refine and define much better what that patient has, if indeed they have anything. Smart algorithms that combine the output of several different types of information are being written as we speak. The ability to take information from a fundus camera, from an OCT, and from a perimeter, and put those information together is very meaningful for your diagnostic abilities. Today, you look at each one of those things in the context of the individual instrument. You have sensitivity and specificity values that are associated individually. Why not have sensitivity and specificity values that are associated with the combination? Obviously, what this will lead to is much earlier diagnosis of patients. Potentially, what it leads to is the ability to preempt a disease before it even begins. Talked a little bit about the human genome. It's still not 100% complete, by the way, for those of you who are interested in the science, but we are so close today. We literally have a manual that will help us build a human being. So what does this mean next? It means that the biotech companies that are involved in trying to move to the next paradigm are looking for diagnosis. They're looking for even what a healthy patient looks like in this combination on the genome. The computing power that is required to understand what the healthy patient looks like, what a patient at risk for disease looks like, and what a patient who may actually have developed the disease looks like is extraordinary. It's highly unlikely that we would want to or even be able to afford the powerful equipment required to generate those data in our own office. This is just another example of how the walls from your office are breaking down and you're reaching out into different communities in order to take better care of your patients. In 1996, first generation OCT from the company that I used to work for cost $90,000. It was very grainy, it had just a few applications, and probably most important, it required a certified photographer or a very highly skilled technician to even get a reasonable result out of the instrument. Today, the converse, and you would expect that instrument, based on inflation, would now sell for in excess of $150,000. Well, the converse is true. The ability of industry and your colleagues, academia, to advance the science has resulted in today an OCT that has about 3 times the resolution and reproducibility, that is useful in the hands of somebody who was flipping burgers last week, and gives you data that is very easy to understand and interpret. The implications of this are simple. The low cost of these instrumentation as we drive the technology forward and the cost down simply means that your office is not the only place that these instruments exist. They will exist in pharmacies, they will exist in retail clinics, they'll exist in company-based clinics. And the fact is that you'll be collecting the data, much like that gentleman in the first picture, bringing that data in through the internet. The Affordable Care Act is just the latest in a series of shockwaves that have affected our ability to diagnose and treat patients. Now, whether you can argue the merits of the Affordable Care Act all day long, but there are 2 things in this that are axiomatic. Number one, we're going to be seeing more patients. Number two, the money that is available to treat each individual patient is much less than what it has been in the past. We have to be able to deal with this and move the ability to diagnose and treat patients forward. The evolving medical economy means that traditional office-based approaches simply may not work in the future. Conducting a percentage of your exams from remote locations has great implications for relieving office congestion because of all these new patients you're going to have to see. It stretches eye care dollars, and it does all this while reducing the total amount of time that it will take to gain a full picture of your patient's diagnosis and treatment requirements. I entered the eye care industry on the other side of the aisle. I was selling pharmaceuticals to ophthalmologists when I first started. Betagan was my big drug. At that time, there were really 4 choices: CAIs, levobunilol, that's beta blockers, and carbonic anhydrase inhibitors, and miotics. Well, of course, we've gotten rid of miotics, but as that slide just blew through too fast, you see you've got really today more than 14 choices. If we go back and look at the nexus point of the diagnosis, the amount of information that's available to us through the human genome, we're actually going to be able to tailor individual solutions to your patients in the very near future. And this is probably not 20 years off. This may be more like 15 years in the future. So, it takes us back to the beginning. Here you are in the cockpit of your office in 2040. Show of hands, how many of you have not yet reached your 40th birthday? I can't see much. Okay, those of you who raised your hands, I have a single suggestion for you. Take flying lessons because you're going to be in that cockpit. Thank you very much.